concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. The BHIPP Warm Line is staffed by a team of child mental health specialists and is available Monday through Friday from 9 a.m. to 5 p.m. And our phone number and website will be placed in the chat for you. It is my pleasure to introduce today's BHIPP Resilience Break, Addressing Sleep Concerns in Pediatric Primary Care, presented by Dr. Antonia Gerard and Dr. Sneha Javad. Dr. Gerard is an assistant professor and licensed psychologist within the Division of Child and Adolescent Psychiatry at the University of Maryland School of Medicine. She graduated from Nova Southeastern University in Fort Lauderdale, Florida in 2014 and completed her postdoctoral fellowship at Mount Washington Pediatric Hospital in Baltimore, Maryland. During her time there following her fellowship, she developed an early intervention program and psychology's role within multidisciplinary pediatric clinics. She currently conducts psychological evaluations through the Center for Infant Study and BHIPP, and supervises Healthy Step specialists embedded in pediatric primary care and family medicine practices. Dr. Sneha Javad is a child and adolescent psychiatrist at the Psychiatric Mental Health Program at Kennedy Krieger Institute and an instructor at Johns Hopkins University School of Medicine. She's involved in collaborative care of children with dysautonomias and works with the Pediatric Postural Orthostatic Tachycardia Syndrome Clinic at Kennedy Krieger Institute. After completing medical school, she worked as a research assistant in the addictions program at Duke University Medical Center before moving on to adult psychiatry training at the University of Louisville in Kentucky. This was followed by a fellowship in child and adolescent psychiatry at Kansas University Medical Center and a fellowship in consult liaison psychiatry at MedStar Georgetown University Hospital in Washington, D.C. Dr. Javad's professional interest lies in multidisciplinary care of children with dysautonomias, other chronic medical illnesses, and somatic symptom disorders. We are very grateful to have you both here today with us. Thank you so much for sharing your expertise with us during this session, and I will hand it over to you guys.
Thank you so much. So just to briefly go over what we'll be talking about today, we'll be discussing the importance of assessing for sleep and what healthy sleep looks like, evidence-based tools for assessing sleep difficulties in pediatric patients, and then discussing sleep hygiene strategies and behavioral interventions, and discussing pharmacologic treatments for sleep problems. So, here we go. So up to 50% of children experience sleep problem, and 40% of teens are impacted by sleep challenges. So that's a lot of kids that struggle with sleep, either with falling asleep, staying asleep, or a combination of both. When we're looking at younger children, more specifically, up to 50% of children over the age of 6 months struggle with waking up throughout the night. Not too surprising, toddlers struggle with bedtime resistance, 10 to 15%. I'm honestly surprised that is not higher with my own experience of having a toddler in the home. And then up to 20% of preschool and young school age children struggle with insomnia symptoms in general. So that can be both nighttime wakings and challenges with falling asleep. And then 20 to 40% of school age children struggle primarily with falling asleep. So with those stats of just the significant number of children in all age ranges that are struggling with sleep, why does it matter? Well, having sleep challenges are tied to a number of concerns. It can lead to an increase chances of developing type 2 diabetes, obesity, high blood pressure, mental health challenges such as anxiety, depression, injuries, inattention, executive dysfunction, so challenges with memory, judgment, focusing, multitasking, impulse control, poor academic performance, and behavior problems. So children may be more defiant, oppositional, aggressive, be more irritable. And then psychiatric disorders are also tied to increased sleep challenges. So not only can challenges with sleep lead to more behavior challenges and emotion dysregulation, but when someone is diagnosed with a psychiatric disorder, oftentimes that co-occurs with the sleep disturbances. So in terms of anxiety disorders, which can affect up to 20% of children, 90% of those diagnosed with anxiety disorder experience sleep problems. And more specifically, with generalized anxiety disorder, 85% of children experience sleep issues. When it comes to OCD, adolescents that have a diagnosis, 50% of them also experience sleep challenges. When it comes to depression, in children, 1% have a diagnosis of depression, about 5% of adolescents do, and 90% with a diagnosis of depression experience sleep challenges. So very commonly in those diagnosed with depression experience issues with sleep. And when it comes to ADHD, 2 to 17% of youth are diagnosed with ADHD, and about 50% experience sleep challenges. And autism, 1 in 36 children have autism, and up to 80% of those with the diagnosis tend to struggle with sleep. So now that we know all of the struggles with sleep, what are the recommendations? How much sleep should children be receiving based on their age? So this is the recommendation based on the American Academy of Sleep Medicine. So not surprising, infants require the most sleep, and it slowly declines up through adolescence and adulthood, where teens should be getting at least 8 to 10 hours of sleep. And the reason the chart starts with infants at 4 months old is because prior to that, infants are just developing at such a rapid pace, and the sleep requirements change so rapidly that it's hard to chart it in such a succinct way. So these are the recommended hours per night total that children in these various age ranges should be receiving. So it's also recommended that primary care providers routinely screen for sleep problems during all routine health visits. And part of that is because caregivers may not think to provide information related to sleep. They may not volunteer that. And they also may not know the potential relationship between sleep problems and daytime behaviors. So they may discuss, daytime concerns without realizing that sleep could be an underlying factor. So there are some screening tools that can be used as a prompt to assess various areas of sleep that should be discussed at primary care visits. And an example of this is called the BEARS, and I'll go into that here in the next slide. So it's a free screening tool, and it assesses 5 domains of sleep. So it assesses for bedtime problems, daytime sleepiness, nighttime awakenings, regulatory and duration of sleep, and then it assesses for the presence of snoring. And then it also breaks it down into the kind of 3 age ranges from toddlerhood, school age, and adolescence. And it has prompts of questions to ask for those 3 age ranges, and also indicates if you should be asking the parent and or the child these questions. So it's pretty quick and easy, but make sure to capture the various areas that can be a struggle for children in their sleep and can indicate a potential for a variety of different sleep disorders. Now, if concerns are identified on a screener like this, and this one is for children ages 2 to 18 years of age. So if there are concerns that are identified on a screener, then a more in-depth history should be obtained. So this is kind of the first step. And if there are concerns, of course, providers should get more information. And this reviews what we would want to obtain. What more information do we need? So that chief sleep complaint is really what the screener pulls for. So it's kind of looking at those initial 5 categories. Is it trouble falling or staying asleep? Is there that daytime sleepiness? Is there snoring? Are there movements, abnormal movements happening throughout the night? But then there also needs to be some additional sleep history that's obtained. You know, what is the sleep-wake schedule for the child? How long have the problems been going on? How frequent do they occur? Does it happen every night, once a week, a few nights a week, once a month? You know, does it coincide with, you know, transitions, holidays when kids are out of school? Are there any interventions or strategies that the parents have tried before? Were they effective? And any daytime symptoms, you know, is there increased irritability in the child? How is their attention? Are they super sleepy during the day? And then also making sure to review the child's medical history. Are there any chronic conditions that are likely to impact sleep? Are there any neurologic disorders? Does a child have a diagnosis of ADHD or anxiety or depression? So as we just looked at, those diagnoses are linked to heightened challenges with sleep. And then another category to look into is medication and substance use. You know, if the child does have a diagnosis of ADHD, are they taking stimulant medications? You know, when are they taking it? Is it wearing off in time for them to be sleepy at bedtime? Are they taking sedating medications? You know, do they take antihistamines, or do they take anti-seizure medications that may have a drowsiness effect to them? Do they consume caffeine right before bed? And of course, in younger kids, you know, are parents thinking about the fact that chocolate has caffeine in it, you know, thinking about sodas. Obviously for adolescents, they may be drinking coffee and you know, consuming other types of caffeinated beverages. And then also, is there any alcohol use, you know, which may help them fall asleep initially, but then can cause insomnia later in the night. So all of these things would be really important information to gather when assessing for any kind of specific sleep disorder. So not only is gathering the history really important when assessing for sleep, but sometimes parents may not have all of the information or may not have thought through, you know, how often are these things occurring? When does the child actually fall asleep at night? How frequently are they waking up? Is there any pattern to when, you know, what nights this is happening versus when it's not happening? And so there are some subjective measures of sleep that can be helpful to track or gather more information from caregivers or from children themselves if they're a little bit older. And one of those is having the family use a sleep diary. There are a ton of different versions of these for free online. This one is borrowed from Texas Children's Hospital. And they essentially, and you can use them for, various different days. This one happens to be for 2 weeks, indicating what time did the child fall asleep, what time did they wake up, and then also rating the quality of sleep as poor, fair, or good, level of quality of alertness during the day, and then the child's mood on awakening. And so these can be changed or finding a different version of sleep diaries if there's other pieces that you're wanting the family to monitor. And then there are also some questionnaires, and we do have copies of the first two. I think we're gonna link to in the chat. And the third one here, you do have, it's free, but you do have to sign a licensing agreement to have access. So we just have the link to that website here so that you can access it that way. So all of these are free to use and assess various different aspects of sleep and are used for slightly different age ranges. So the Children's Sleep Habits Questionnaire is consists of 33 scoreable items. It's for children ages 4 to 10 years, and it assesses bedtime behavior and sleep onset, sleep duration, any anxiety around sleep, behaviors occurring during sleep and night wakings, sleep disordered breathing, parasomnias, and morning waking and daytime sleepiness. The second one is the Epworth Sleepiness Scale for Children and Adolescents. This one is for children ages 6 to 16, and it's 8 questions, so very quick. And it is specifically for assessing daytime sleepiness. And then the third one here is the Pediatric Sleep Questionnaire. It is 22 items. It's for ages 2 to 18, and it assesses 3 domains. So it looks at sleepiness, snoring, and inattention and hyperactivity. So these can be used based on the age of the patient and what specific concerns the parent had voiced either through the BEAR screener and then that history that you obtained to get a little bit more information and more specifics as you're determining what potential sleep disorder may fit their presentation best. There are also a couple of objective assessments for sleep. So I'm going to go over 2 of those. So the polysomnography is kind of that traditional go to a sleep lab, stay overnight, get hooked up to a bunch of wires and sensors. This can be used to assess for snoring plus other things that are going on, so other sleep disorders, other breathing concerns. It also can monitor for movement related sleep disorders. It can rule out narcolepsy, idiopathic hypersomnia, and also persistent and treatment-resistant sleep disturbances. So it's a little bit more invasive than some of the other sleep monitors, but can really help for some of these more complex sleep presentations. And then we also have the actigraphy, which monitors sleep and wake cycles throughout the night and monitors movement. It looks kind of like a watch. You wear it on your wrist. And it can be used to assess the circadian sleep-wake rhythm disorders. It can assess for insomnia, so how long it takes to fall asleep, or if there are night wakings, how frequently they occur, how long they last. And then also for excessive daytime sleepiness. And then it's also a really nice tool to monitor treatment responses. So once a treatment is being implemented, this can be used to track whether or not it's working, to see if a child is receiving more sleep or having fewer nighttime wakings, or are they actually falling asleep earlier, depending on where the concern lies and whether it's working or not. And not surprising, this is more accurate than a sleep diary, because it's not requiring a parent to, monitor when a child is actually falling asleep or how frequently wakings are occurring, which of course is at night when parents are likely also trying to sleep, and, other things that may get in the way of getting fully accurate data. This is more accurate. And then getting into the intervention piece of things, the first is just overall sleep hygiene. So just good sleep practice that is helpful information to share, really with all caregivers and children. So the first one being to stick to the same bedtime and wake time every day, even on weekends. Staying up late on weekends or on holidays can be a challenge then when children have to catch up on sleep and throw them off when they're having to get back to a schedule once school starts again. Another piece is beds are for sleeping. Beds should not be used for watching TV, playing on electronics. We really want the brain to associate the bed with sleep. Having a comfy, cozy room is really important. So making a child's bedroom cool, quiet, calm, comfortable. Alarm clocks are used for waking up. So this is for a little bit older children or adolescents. If they tend to stare at the alarm clock, just kind of waiting and hoping to fall asleep, they should have the alarm clock turned away from them, or if it needs to be removed so that they're not just staring at the time. Bedtime routines are really important. Having a predictable series of events that lead up to bedtime. So this can include kind of the usual pieces of brushing teeth, putting on pajamas, maybe reading a story, reading a book before bed, and making sure that the activities that are leading up to bedtime are quiet and calm and relaxing. So this can be listening to calming music. It can be, again, reading a book. It should not include any kind of screens, no TV watching, no video games, no phones, all screens should be turned off at least an hour before bedtime. Teaching children how to relax is really important. So good examples of this are deep breathing exercises, some mindfulness strategies. So like thinking of positive images can be very helpful. Exercise, especially in the morning, can be very beneficial. That can help children feel more energetic and awake during the day, have an easier time focusing, and can even help children fall asleep and stay asleep at night. And as I mentioned earlier, avoid caffeine, especially later in the afternoon and in the evening. If you can't sleep, getting out of bed. If a child's tossing and turning, have them get out of bed and do something that's not too stimulating. So like reading a boring book. So for like older children, adolescents, this could be like a textbook, and they can return to bed once they're sleepy again. If they're still awake after 20 to 30 minutes, they can repeat the process and then get back in bed about 20 minutes later. And the goal of doing this is to prevent the bed from being associated with sleeplessness. Putting kids to sleep drowsy but awake. So the reason why this is ideal is if a child falls asleep in places other than their bed, it teaches them to associate sleep with places other than their bed. It also doesn't allow for children to learn how to self-soothe and comfort themselves to allow themselves to fall asleep. So then parents get stuck in that trap of having to be the ones to put their child to sleep. Cuddling a stuffed animal, a blanket, something that's just soft and cozy can be really helpful at bedtime. Any bedtime checkup should be really short and sweet, not giving too much attention, not being overly stimulating. The shorter, the better. And then that sleep diary. So tracking naps, bedtimes, wake times, any behaviors to find patterns on what's working or what's not working when things are not going well, again, can be really helpful to figure out and problem solve. And then more specific interventions for treatment of behavioral insomnias. So focusing on behavioral insomnias of childhood, because if it has a behavioral base, we can treat it with behavioral interventions. So children that are used to, crying and whining gets parents to stay in the room or not leave them until they fall asleep, or if they wake up and, are asking for parents' attention. These are some examples of behavioral insomnias. So one way to help reduce insomnia is having that bedtime routine. So again, having soothing activities, taking a bath, change into pajamas, reading stories, no electronics, having some kind of cuddly object, a blanket, a stuffed animal, putting the child to bed drowsy but awake. So again, that's going to help minimize that dependence on the parent being present at sleep onset. And the bedtime should coincide with the child's natural sleep onset time. Another strategy to use, and so finding what works best for the family and what they're most likely to stick with. So there's extinction, both unmodified and gradual. Unmodified extinction is the fancy term for crying it out. So this involves just putting the child to bed at a designated bedtime and then ignoring the child until the next morning at whatever set time. So even though this is a very successful strategy, a lot of families have a very hard time with it. It's not acceptable to a lot of families. It's just hard to tolerate a child screaming and crying and protesting. And then they're more likely to go into the room when a child is escalating and really then inadvertently reinforcing heightened behaviors. So, if a child is normally crying and the parent walks in, they start to, maybe implement extinction. So the child's crying, the parent's trying to ignore, now the child's, throwing things and becoming maybe more aggressive. The parent now can't tolerate it, goes in. The child is now learning, well, the crying didn't work. Now I have to use these escalated behaviors to get your attention. Next thing you know, this family's back in your office saying, this didn't work. Now my child's worse. Well, you reinforce the worst behavior. And a lot of times behaviors get worse before they get better. So this gradual extinction can sometimes be more tolerable for families. And this involves again, putting the child to bed drowsy but awake, and then waiting longer periods of time before checking on the child. So each night, the initial waiting period before checking on can be increased by a specific number of minutes, reassuring the child. And during those visits should be really brief. Contact should be really brief, should not be picking up the child. Maybe just like a little pat for comfort. And then fading that out over time. Another way to do this is if the child is used to, you laying in their bed at bedtime, it may then involve, sitting in a chair next to the bed, and then slowly, moving the chair closer to the door, then sitting outside the door, then in the hallway. And the time it takes to fully implement this intervention can depend on the child and consistency and how easily the child's able to adjust to each shift. So it may take a couple nights of the chair being next to the bed and then moving it, or it might just be night by night. Bedtime fading is another strategy. This involves initially setting a bedtime. So this is specifically for when a child has trouble falling asleep. So if a child, bedtime is at 8, but they consistently do not fall asleep until 11, this technique involves setting their bedtime for lights out at 11, and then slowly moving that time up. Then it would be 10:30, then 10. And so the idea is that being able to set it when a child is more physiologically ready for sleep, then you can kind of gradually modify their circadian preference over a period of several weeks. And then the last strategy we'll discuss here is positive reinforcement. Sticker charts can be really beneficial for preschoolers and even older children. A note for families is that the most effective way to implement this is if rewards can be earned immediately. So, for example, this sticker reward should be given first thing in the morning if the child's met their goal. The goal also has to be attainable. So a child may be able to initially earn a sticker just for sleeping in their own bed all night, even if they're constantly calling for their parents all night long or until they fall asleep, and then can slowly address the more challenging goals and implementing those. Because if the child can't reach the goal, the reinforcer, the sticker chart won't be beneficial because they've never even been able to earn a sticker. So you have to kind of meet them where they're at and then can kind of build what the goals are. And then for school-age children, rewards can be modified. You can change them based on their interests, but still being concrete and immediate. They should still be able to get them, first thing in the morning. Small rewards are usually more effective, and if they can get them more frequently than fewer large rewards. And then another intervention that is recommended for older school-age children and adolescents for insomnia is when sleep-related challenges are more conditioned. So we were looking at behavioral. This is more so like if it's perpetuated by anxiety, and may even be kind of a presenting symptom of more of like a generalized anxiety disorder. Could be a circadian rhythm disturbance or kind of a combination of these things. So CBTI typically is for like 6 to 8 sessions and has 5 components. The first component being sleep hygiene and education. So this consists of, what we talked about on that blue slide. So how to practice good sleep hygiene, diet, exercise, having a nice, calm sleep environment. And then the second component is stimulus control. So that's going to bed only when you're sleepy, using the bed and bedroom only for sleep. If you're in bed and unable to sleep, getting out of bed, only returning when you're sleepy. Usually this is, again, within about 20 minutes or so. So getting up at the same time in the morning, regardless of how much sleep was obtained, and not napping during the day. And then the third component of sleep restriction, you start by calculating the total time spent in bed on a typical night using a sleep diary, and then adjust plus 30 minutes. So for example, if you get 5 hours of sleep, you adjust your bedtime to spend 5 hours and 30 minutes in bed versus, you're laying and tossing and turning for 8 hours in bed, but you're really only sleeping for 5. And then relaxation training. So that involves learning strategies such as progressive muscle relaxation, mindfulness skills, deep breathing strategies, and then the cognitive component. So that's the cognitive restructuring, where children learn how to identify, challenge, and alter their thoughts and beliefs that are contributing to their insomnia. Okay, so now I am going to turn things over to Dr. Chadha.
Hello. Okay. So I'm Sneha Jadhav. I'm child psychiatry at Kennedy Krieger, as Lillian already said. I have a few slides, points on the treatment and the pharmacology part that I'm going to get through hopefully a little bit quickly. And then if we want to, we can definitely go back to some of it. I don't have the slides. So I put this in here because with sleep, we talk about meds and things that have, or disorders that affect REM and non-REM. And it helps me to look at this picture every so often and also talk to families when we're talking about a treatment plan. Even very basics like that initial part of the night is meant for deep restorative sleep. And then as we move through the night towards early morning, that is more of our brain doing active work in terms of working on our cognitive capacity, on memory, on learning, cognitive and emotional learning. So that, and then when it comes down to kids or teenagers, adults being on other medication, helps things think through where, like, are we starting with thinking about what the contributing factors are and limiting those, or are we already at the point of talking about another intervention, additional intervention to treat sleep? So non-REM, of which the 3 step portions, N3 is the deepest sleep, and then the REM sleep is more where the brain is still doing sort of active work. And the REM sleep does go on increasing in proportion as we get through the night. And then in the initial part, we have more of the N3 and more of deep sleep. Could we go to the next slide, please? And as you already said, poor sleep causes a lot of different issues. Almost all psychological symptoms worsen with poor sleep. It is a risk factor for self-harm, even by itself. Physical growth, physical illness, and if kids have a chronic pain condition, it affects how they manage pain. Can we go to the next slide, please? So a few rule outs as we start talking about sleep. And what's not on there, but I do kind of realize this every time, is knowing about what the family's practices and comfort and beliefs around sleep are. It kind of just sets a very different tone in terms of the treatment plan and whether we're going to keep going back and forth with implementation or we're going to make small steps, because that's all we get, small steps. So how do they feel about very structured bedtimes? Or is it practically possible to implement it? If the kids get loud during the implementation, is that okay? Like in the setting that they're living in, are there other kids in the house? Why does she get to stay up and I don't? So knowing all of those sort of practical limitations helps. And we've talked a great deal about sleep hygiene. We all know about that part. Eating and delaying bedtime for an additional snack does come up a fair bit, especially for me and everybody, and especially if they are in the population that we're also talking about ADHD medicine and kind of pushing that rebound appetite issue for later in the day. Any psychiatric, psychological disorders, but anxiety and ADHD being very, very common, other medication affecting sleep, and then common, but very specifically sleep-related issues like iron deficiency, bedwetting issues, pain, obviously for everything, and sleep apnea. And could we go to the next one, please? And so I put a few or several medicines on there and depression to just kind of make that visual of, yes, we talk about sleep habits and kids' traits and family behavior. There is a real sort of element of how, and I did not put ADHD on there, or somehow it went off. But there is a very real component in mood and anxiety and ADHD that affects the structure of sleep. Kids that are on SSRIs have sleep-related side effects, nightmares, very vivid dreaming, and then sometimes sedation. Stimulants, as we know, definitely affect bedtimes and bedtime routines. The actual insomnia from stimulants they would really have to be in the system to cause that insomnia, which I think is fairly or more easily fixable. We know to use stimulants earlier in the day, not late in the afternoon, not use the long-acting ones later in the day. So I feel like at least we know how to work around that. There is that other elements of when stimulants have fairly well worn off later, late afternoon or whenever. And then there is this gap of very dysregulated 3, 4, 5 hours. And then the child has to go to bed. And then that routine, I mean, with our best efforts and best routine in that last 1 hour, just thinking about their cycle throughout the day, they have they wake up with a fair bit of dysregulation. Then they have a lot of support, depending on how much medication, for 2/3 or half of the day. Then they're really dysregulated if they don't have any medication support in the evening. And then we have another set of strategies for sleep. So if that's the pattern, that's kind of the other part of how associated with use of stimulants, but not really a side effect, but it affects sleep. And then again, if they're getting really hungry later in the day with the use of stimulants, that we're just setting up a lot of reasons for delayed bedtime. All antidepressants have some effect on sleep. The tricyclics especially tend to be more sedating. We don't use them as much for depression in kids, but they still do get used for kids who have chronic stomach issues, headaches, migraines, a few other situations. Antipsychotics, again, hopefully less overall use, but they can cause a lot of sedation during the day. And then some of these kids on any mood stabilizers will have some of their energy come back later in the evening, depending upon the dosing of the medication. And then anti-epileptics, beta blockers, and hopefully there's not the use of Z drugs and benzodiazepines in kids is hopefully lower or minimal or not there. But they all have a pretty big impact on sleep structure and very clear sleep-related side effects. So ruling in, ruling out some of these factors, I guess, is the point of the slide. Could we go to the next one, please? And then what do we do how do we address sleep? We hopefully get through sleep hygiene with most, if not all families, hopefully all. And then we come to melatonin very often. So we're very familiar with the use. Reiterating some of the points is that it does have a short half-life. It is good with sleep initiation. It is going to have a harder time helping with maintenance. And then depending upon whether we are attempting to address sleep phase issues or we are trying to help with sedation, how much and when the melatonin is taken does make a difference, and we want to match it with the indication better. It is metabolized by the 1A2 system. There are not, the 1A2 list of substrates and inducers is not long, but it is there. There are a good number of drugs that also use that pathway. So looking for interactions. And then food has an effect on the onset of action. The supplements that are available have a very wide range of melatonin content. And I'm sorry, it should say decreases N1. It looks like NI. So it decreases the light sleep and helps the onset of sleep is quicker. The sleep latency decreases. Onset of deep sleep is earlier. Onset of deep sleep is earlier. So it improves the ease of falling asleep and getting into deep sleep. It does not affect the total sleep time. So kids who have an issue with waking up super early are still gonna wake up super early. And it doesn't directly affect daytime functioning. Could we go to the next slide, please? And so a little bit more about, again, our common sleep medication measures. Melatonin, we talked about a little bit, and most of it is repetition of the previous slide. It does have side effects. Majority of the time, thankfully, we don't run into side effects. Can cause hypotension, bradycardia, and affect the seizure threshold. The growth hormone and gonadotrophin secretion is really tied into our circadian rhythm, so does have an impact on those. Antihistamines come up fairly frequently in kids who are unable to sleep. Hopefully the use is when we are worried about allergy conditions as well, and then using them at bedtime does help both situations. Alpha agonists also come up a fair bit, hopefully when sleep is comorbid in the ADHD context. Of the two alpha agonists, clonidine is slightly more sedating than guanfacine is. The IR version tends to be more sedating and more immediate effect, as we know, than the long-acting one. Both they also have their side effects in terms of hypertension. With the shorter acting ones, especially the rebound hypertension can be a concern. And then some kids, whether the description is like they're in really deep sleep, or if it's other factors, will have either a recurrence or some increase in nocturnal enuresis on these medicines. And yes, I mean, in the setting of while we're trying to treat ADHD, they can help with the comorbid insomnia. And I think I may have one more slide. Skip the next one, or maybe that. Yeah, that was all of mine. Thank you for listening.
Hey, thank you so much, Dr. Gerard and Dr. Jabhad, for that wonderful presentation. We did have a question or two placed into the chat. One of them was, where can you buy that watch? I think it was the actigraphy. If you guys know.
So there's a few options. In a lot of the studies, it seems like they use a Philips brand one, and then they have I think it's called AMI that they use in a lot of the studies that, so in terms of making sure that it is a very accurate one. There's even potential, it seems like most insurances won't cover it, but it's possible and is worth submitting to insurance to see, depending. So that's certainly something for to have families look into. And then even like if doing it on a little bit less of a formal basis, even like if you have an Apple Watch, they're actually quite accurate as well. So if patients already have something like that, you know, especially for older kids or adolescents, they can use, or like, you know, some of the other tracking devices that kids may be wearing, they can use that as well.
It looks like we have another one. Any particular suggestion for kids with autism who seem to get very little sleep?
In terms of behavioral intervention wise, similar to the other pieces that we talked about, you know, for younger children, or kind of even regardless of what other things may be going on diagnostically for them, can be really helpful. You know, there's a lot of oftentimes sensory overstimulation. So having that routine, that quiet time before bed is going to be really important. You know, making sure screens and things are turned off. You know, autistic youth really tend to thrive on having knowing, you know, what's coming next. So having a very structured bedtime routine, maybe needing to take it a step farther and having like a visual schedule of first brushing teeth, then putting on pajamas, then reading a book, can be really beneficial for them. Things like weighted blankets, a lot of families have had success with, or if, you know, they tend to prefer maybe more like compression clothing or loose fitting clothing, you know, finding things based on any sensory concerns or sensory seeking things that might be helpful for them. So those are, you know, even with autism, there's such a range of what could be causing the sleep disturbances. So it really depends based on the child, but those are some of the global pieces.
I think those two were the things I was thinking about also, is how much of repetition they have at bedtime, or how much they need, either way. And then whether they have a lot of sensory we just need to kind of step back from, or they don't have the sensory support that they need, I guess. Yeah, those two were.
Great.
I will say, in working with a lot of autistic youth, you know, the like holiday breaks, summer breaks are usually a nightmare for sleep because their schedules are thrown off, you know, so really that sticking to the same bedtime, the same wake time, you know, all throughout the year, regardless of what's going on, is really, really important.
We have a couple other questions. Next one is thoughts on small doses of trazodone for sleep in older kids.
So with sleep, because I'm okay, but because sleep, we're focusing on a symptom. Just the way I think about it is, like I want to have some sense of what the main contributing factors are. Not, I mean, the ones that we talked about, like managing in a more behavioral pattern, but also in terms of what underlying disorder, if any, is contributing. So if there is a very clear pattern of depression and there is some room or need to address depression, and trazodone comes in, that's when I think of trazodone. And the second part is any medication we're putting on board. I with families, that's kind of my discussion, is we want to have enough of an indication that we're going to use this medicine through its full range and feel comfortable, or around side effects. So we should have enough of an indication that if we say, okay, this side effects is tolerable, we still have our indication, we're going to keep going. In that setting, any medication. And so if there isn't a mood component, I've typically not gone to trazodone, even for the older or for teenagers. Trazodone affects the deep sleep part of the sleep cycle, which is why so it also increases like the total sleep time. And so I do worry a bit about that spill of sedation during the day, or just that sort of this slow cognition during the day. So that side effect or that effect is always going to be there. And so having enough of an indication, because I wouldn't start trazodone with I'm going to do 50. If it doesn't work, then we're going to switch. I guess that's where decision-making lands for me.
Thank you. I think this question is referring when we were speaking about kids with autism and their sleep. And it said, what are your thoughts about a weighted blanket?
Yes, definitely worth a try. A lot of kids respond with or without autism tend to enjoy weighted blankets.
We have another one. For melatonin, do you typically tell them to use for a certain duration of time to reset sleep cycle or use long term?
And so with melatonin, and I think with most sleep measures, maybe, but so at least from my point of view, I do say this is the dose we would start at. If you're in the second or third step, then a range. But for this duration, these many, like right at bedtime, if you're, or closer, like 30 minutes, if you're trying to get that sedation as the main effect, much sooner if we are working with the sleep phase. So that part, and then the next part is, from my point of view, I do make a plan of like either 4 weeks or 6 weeks or however long. And then at that point, with the other measures in place, the idea is to come off of melatonin. So the plan when starting melatonin for me is never from now on, ongoing type of thing. And I do ask families to stop melatonin once we've gotten to that period, and then we reassess and what all has been implemented or not, and if not, and change some of those things. But then do another cycle. So it's not that 4 or 6 or 8 week cycle is successful, but there is that reassessment pause there.
Right. We had another question. What age is it okay to use the weighted blanket?
I don't know that there's necessarily a specific age. I mean, obviously, in terms of like safe sleep habits with infants, when we don't want any kind of blankets or things in the crib with a child. But outside of that, it really it can really be used whenever. There's different weights as well. So um, um, you know, just being mindful of the various different weights. But aside from what's safe for infants, there's really no like age limitation of when you can start.
Great, thank you. Another question is, when is it best to start discussion about extinction method for sleep? Is there an age that it's too late for it to be effective?
Good question. I mean, the earlier the better, but it's never too late. It's just, you know, the longer the child has been able to engage in such behaviors and it's been reinforced, it may take longer to undo those poor sleep habits. But you know, certainly there's not a point where it's like, well, it's gone on too long. You know, there's no hope. There's always opportunity for change, and certainly worth addressing, especially if it's impacting the child's sleep and cause for concern for the parents.
Okay, any other questions? I think that might be it. Okay, thank you again for this wonderful presentation, Dr. Gerard and Dr. Javad, and to our participants in today's session. The recording for today's session, the slides, and also a list of related resources will be available on our website next week, and we will send CME and CU certificates to participants by November 29th. Please remember to take the survey as you exit, as this is required if you'd like to receive a CME or CU certificate, and we will also send the link to you via email after this training. And stay tuned for future BHIPP Resilience Break and other BHIPS trainings by following us on LinkedIn, Facebook, and Twitter. And thank you so much again, and I hope everyone has a great rest of their day.
So much for having us. Take care.
Thank you.